Good morning, everyone. Now we are going to discuss what the initial stabilization in sepsis. In the early two lectures, you now aware what is the sepsis, how to recognize the sepsis. But now is the time to act of the sepsis. We see how it, and the sepsis is a killer. We need to act timely. If the time factor is very important as a with the action. The time versus action and how to act promptly with the time we discuss in this lecture. And as we earlier discussed, need early identification. And just I go to one stool because it is single. There's no single stool to identify the sepsis. The old tool identifies the patient is critically unwell or unstable. See, but how you take the identify sepsis and then how to act. For example, now we are know with as a, in Sri Lanka we are going to move with the national early warning scoring system. Therefore, I will more adhere to that one and go with you how to direct the initial stabilization with that. Because you know the QSOPA, SOPA, and News, Muse, and various scoring systems who identify the patient instability. I get one, and we will go move on. Now, there's the news score. News 2 is a newest, now currently using in the old the UK and Australia and the things. Uh, Mainly based on the physiological parameters, respiratory rate, oxygen saturation, systolic blood pressure, pulse, level of consciousness, and the temperature. And this context, how to use. If someone says this news story is more than 5 or above, or even is less than 5, or if the patient looks still unwell, what should we do? And then think about it, could this be due to an infection? For example, the pneumonia, patient is PU and co, UTI, abdominal pain, with maybe an intra-abdominal sepsis, cellulitis, septic arthritis, infected too, or either device-related infection, meningitis. Or this source is unknown with the patient showing features of sepsis. The PU is ongoing. Focus on that, and then focus on any red flag sign of one of these. Is there? If the patient is respond only to voice or pain, the blood pressure is low, less than 90, or less than. This is important to identify the blood pressure in elderly patient because it drops more than 40 from the normal. Systolic blood pressure is important because it's still patient is shocked. With, for example, the hypertensive patient, if the systolic blood pressure is maintaining like this, is 160, 110 like this, is the now it dropped to 140, even 130 like this. This patient have significant clinically, according to blood pressure, patient is shocked. The heart rate, the next one is 130. The respiratory rate 25. Oxygen saturation, need oxygen or keep the saturation above 92. Maybe rashes, sun blanching rashes, model, and the patient looks cyanotic and not pass urine at least last 20 hours, sorry, 40, for 18 hours, and urine output less than 0.5 ml per kg per, and lactate about 2 or recent chemotherapy. Like if some red flag is present, and then what should you do? What the action plan is? The action plan is for sepsis is the bundle care. The bundle care is the currently we are practicing what bundle care is the sepsis sick tool. The step to save life within 1 hour bundle. What the simple measures to take into action with immediately to save the life. Okay, shall we start sepsis six pathway? There are 6 elements you need to perform within 1 hour. Once you identify this patient is as sepsis. What sepsis is care? Is need to give high oxygen via non-resistant face mask. Give IV antibiotic according to local protocol. Start IV fluid resuscitation, balance crystalloid, and take blood culture and consider source control. And check lactate and monitor urine output hourly, and we need to consider catheterization. That's 6 we need to implement without delay within 1 hour. Compliance with the sepsis checks has shown to reduce the relative risk of death by 46%. It means that one additional life is likely to be saved for every 5 case care episode. Okay, go one by one. We'll see what we see. First thing is administer oxygen. Oxygen is a drug, not to give liberally for age and everything. And we have a target saturation for that. Aim to keep the saturation above 94. If patient is risk of hypercapnic respiratory failure, and then we keep the patient saturation between 88 to 92, it's like patient with COPD and maybe chronic lung disease and requiring having chronic respiratory failure disease. And then we need to target the saturation is 88 to 92. But sometime there are issues because if the saturation is always a correct because patient in the shock, patient saturation detection is might be wrong because the peripheral perfusion is less. Therefore, some friction will arise. And if you are doubt, always give oxygen. That's the thing because the patient is shock, patient is activating the anaerobic cascade and the anaerobic environment in the low give oxygen. If you are not thinking of the saturation level, detection is not correct. And then IV fluid. Yes, how to give IV fluid and how what are the conditions we need to consider. Give IV fluid is hypotensive. If a lactate too, we can start 500 ml initial that as a bolus and may repeat it if still the blood pressure is low. We can use up to 30 ml per kg, but it's not as liberally. And what we need to do, the fluid administration might be we can give 10 ml per kg here, and then maybe a 20 ml, or either increment, or either we need to go to early vasopressin. For example, the patient is a heart failure or elderly patient, and we need to think how to start fluid. Whether we need to go with the increment like 250 ml, or whether need to give 10 ml per kg, for example, maybe 500 ml. Like that, you need to decide what the best for the individual base care. And this patient in critically unwell is no heart failure, the patient is shock, then might be 20 ml might be best. If patient blood pressure is unrecordable, then 20 need to give 20 ml per kg. Like that, up to 1 hour, we need to complete the 30 ml per kg. But during that, you need to think whether patient can tolerate fluid or still require fluid. And because might be need, you start early vasopressor in that case. How to do that? And fluid responsiveness in initial phase is we can't go for very high stuff and need to use some bedside too. And one thing is we can use passive leg dressing test. With the passive leg dressing test, this is you if you patient can give, but need to this passive leg dressing test before starting inotrope. Because after starting inotrope, the passive leg dressing test is not valid. And if you give fluid, this patient is not responding, and you are worried about the patient is in the cardiac dysfunction or renal impairment or something, and just do passive leg dressing test, this patient is not dyspneic, and see whether his fluid is responsive. Because if the patient own compartment fluid is going, and you can adjust whether still need fluid. Other thing is the point of care ultrasound. It's a bedside tool. We can see in IVC diamine, the IVC collapsibility, whether we can still need fluid. But be cautious, this IVC is not validated for spontaneous breathing patient. All are ventilated patient, but it's using and the emergency department in the initial workup, we can use as a surrogate mark, but don't fix into that because this IVC in spontaneous breathing patient still not validated in the any research. But we need to combine other thing is get more combined result like cardiac contractility. You can put the probe into the heart and see if the heart is contracted. It's hypol contractility is enough. You can go if you have basic knowledge about the ultrasound, and then it might work in the lung ultrasound. See whether his lung is wetting earlier. It is lung, it might be early features of pulmonary edema. And gathering all three, IVC, cardiac arrest, lung ultrasound, and you can make some clinical judgment how am I going to give fluid. Is it too much or too less, or either it is rational, and need to start early vasopressin. And recommended crystalloid fluid as a first line resuscitation, not a colloid. But in now it suggests balanced crystalloid over normal saline. Because if we are giving a normal saline as a liberally, it will go for hypochloremic metabolic acidosis. It is acid base balance. But doing ringalactate, Hartmann is much better in our country. In Sri Lanka, we have the ringalactate. But the plasmolite solution is available is much, but is not available in Sri Lanka. I think give balanced crystalloid rather than the normal saline for the initial workup. And if you think this patient require early vasopressor therapy, start vasopressin as a first line vasopressor. No, noradrenaline as a first line vasopressor. And you can start peripherally to avoid the delay. In first, up to first 4 hours, we can use the peripheral line, but be cautious if the patient is vascular disease, peripheral vascular disease like patient can chance of due to extravasation and gangrene earlier. Keep on mind, but you can use still the vasopressor peripherally as a life-saving measure. And there's insufficient evidence for restrictive fluid versus liberal fluid strategy after initial fluid resuscitation. And this remains an important area for further research and study. And the vasoactive agent management, because it is not in the sepsis 6, but we need to act, it's going to hand with IV fluid. Use noradrenaline as a first line vasopressor. Now with the dopamine is a bit of out of choice, and initially they are thinking with the dopamine also we can use. And target NAP is 65. And consider invasive monitoring of arterial blood pressure, not a normal BP cup. Early arterial line placement is better. If the MAP is inadequate, despite low to moderate noradrenaline infusion, consider vasopressin. And don't go for higher noradrenaline dose very early, like 1 micro kg, and you start go with the moderate dose and then go for the vasopressin earlier. If it's still the MAP is inadequate. If you think the patient in cardiac dysfunction is a myocardial infarction or myocarditis thing, the persistent hypotension persists, adding dobutamine is better, or switch to adrenaline. And take blood culture, at least the peripheral set. Also consider CSF culture, urine culture, sputum culture accordingly. According to the time, don't delay administering antibiotics. Think about blood culture. For example, if the patient is meningitis, if you think with the patient is lumbar puncture, still you need to give if this delay happen, need to give antibiotic and then go for lumbar puncture. Still, patient outcome is superior giving IV antibiotic early. IV antibiotic, how to give? Is a broad spectrum according to local protocol. As you know, now we having a newest guideline published by microbiologists, our local antibiotic policy. And also consider allergic prior to administration, because it is you don't jump into second catastrophic situation, second shock if you not consider about allergy. Therefore, please consider the allergy status of the patient. And then the serial lactate collaborate with the VPG is that this is high lactate. This is arterial AB. You see whether it's confirmed. With lactate is 4. Call critical care outreach and consider need ICU care early. And reject lactate is 10 ml per kg fluid challenge. And the last with the sepsis it may require urinary catheter because need to measure urine output and ensure fluid balance chart comment and complete hourly urine output. And after 6 hour bundle, if it's septic focus, if you identify, go for early surgical intervention. Neither soap control. Thank you.